Hi, everyone. Welcome to ABCs of Anesthesia. And today I have Ruth. Now, Ruth is one of our operations managers, really. So she runs a lot of the organization for the med student and other tutorials with ABCs of Anesthesia. Welcome, Ruth. How are you going?
Great. Thank you so much for having me, Lahiru.
No, it's great. Look, you did a bit of work on just looking at on researching about rapid sequence inductions. You're about to go into your crit care year, and I thought this would be a great time that we could chat about rapid sequence induction and just really go through all the basics of it and also share some experience as well. So what do you reckon? Why are we covering RSI? Like, what do you know about it?
Yeah, well, I guess as a junior doctor, RSI, it's something I'd only really seen being done in the emergency department, often really high acuity situations. And, you want to get in and ask questions, but you're always trying to find that balance of, asking at the right time. So, yeah, I guess I wanted to do a bit more research into RSI and, get a bit more understanding of why it's done, when is it used, and what are the steps involved and risks and benefits for the patient.
Fantastic. So we'll go through why it's done, when it's used, what are the steps, risks and benefits. And it's amazing. It's actually interesting you say it's always done in ED in a high acuity situation, and often it's done in anesthesia in a high acuity situation. And when we go through it, we'll kind of outline the fact that this is a little bit, risky, because essentially we're giving these predetermined doses, which have lots of risk with them, in some of the most unstable patients. So yeah, rapid sequence inductions innately are more high risk than other inductions for a number of reasons. So what does RSI or rapid sequence induction mean, and why do we do it? And I guess what are some examples that you've seen?
So I guess the goal of rapid sequence induction is to minimize the time of an unprotected airway. So you want that immediate unresponsiveness, so the induction component, and then muscular relaxation, so administering your neuromuscular blockade. So from my reading, the classic RSI, you give your IV induction medication followed by your rapid neuromuscular blockade with cricoid pressure, and then you go on to intubate in rapid succession to prevent any aspiration. And this, from what I've been reading, this has been out since the 1970s was when this method was first described, but now with new technology, medications, change in practice, this has now evolved, and there's certainly different approaches to this technique as well. So I guess a particular situation where I've seen RSI, is in the emergency department resus situation. You've got a presumed unfasted patient, in a peri-arrest situation. And so really, you want anaesthetics, ICU, ED, all involved, working together to kind of intubate as quickly as possible and minimize the risk of aspiration.
Yeah. And as we'll go through later, it feels unusual because every rapid sequence induction now is different to the described technique previously, whereas literally predetermined dose of thiopentone, you don't even wait for the patient to be unconscious. You just give the succinylcholine again at a predetermined dose. And yet, as soon as you see those fasciculations, and then you put the, you intubate the patient with cricoid on without any ventilation, unlike normal inductions where you paralyze the patient and there's probably a longer time, not that 30-second window, and you're ventilating them, making sure they don't become hypoxemic. You're trying to do all these things to prevent aspiration. But yeah, literally all you need is your anesthetic nurse and the airway manager, and it could be ICU, ED, or anesthetics. So what are the ideal induction agents for rapid sequence induction?
Yeah, well, as I was doing some research, I was like, what is the number one choice? And there doesn't seem to be a number one choice, unfortunately, but there's certainly different properties that you would like your induction agent to have. So you want your patient to become as quickly unconscious, unresponsive, and amnestic. You want it to have some analgesic properties. In doing this, you want to try and maintain their hemodynamics and cerebral perfusion pressure as much as possible. Ideally be immediately reversible as well. So, if things aren't going to plan, you can reverse the effects as quickly as possible and also have minimal side effects to the patient as well. So they're the kind of, ideal things, but there is no one perfect agent out there.
That's right. I'm thinking, was essentially what we're really trying to do is just get the fastest agents, and pretty much all our induction agents are fast really now. But, propofol and thiopentone, they essentially can really create hemodynamic problems and hypotension. in any patient, let alone someone who's, got, an emergency patient with, blood loss and other problems. And, and then the other drugs like ketamine is pretty stable, but it doesn't, it can definitely drop the blood pressure, but it has direct negative inotropic effects. There's a drug called etomidate. I don't know if you've heard of that one. No.
Yeah, vaguely in reading, but doesn't seem to be used much in Australia. Is that right?
Yeah, not used in Australia, but used in many other countries, used in New Zealand. So in our exams, we have to learn etomidate. It's a New Zealand and Australian exam. It's available in New Zealand, but just not available in Australia. There's evidence that in sick patients, it has it decreases corticosteroid production, which can have effects in long-term morbidity and mortality for patients, especially these sick patients. So yeah, we don't have that in Australia. So what are the drugs that we use when performing an RSI? And let's go through some kind of the areas of contention and what things people often swap in for other for parts of these methods.
Yeah, so the traditional method, the one that was kind of first described in the 1970s, that's your thiopentone, suxamethonium. You do your cricoid, or also known as Sellick's maneuver, and then go on to intubate the patient. So that's your traditional method.
And without any ventilations as well. Yep.
And I guess, going away from that technique with, new drugs, particularly propofol, research into RSI and, looking at the actual risks of aspiration with, minor changes to the techniques as well. So that's kind of why I guess have gone away from that traditional approach. Would you agree with that, Lahiru?
Yeah, I mean, I think so. Every single person that I've ever seen doing an RSI these days is not doing the traditional approach, mainly because even if you're using thiopentone, which early in my training would use it occasionally, we still would wait until the patient is asleep or has eyes closed, so they're hypnotized, just so that we're absolutely guaranteed of the fact that the patient isn't given muscle relaxant and they have any kind of recollection of this. So we'd always do it outside of the traditional sequence. And these days, thiopentone is actually, out of production. I feel like there's over time, because it's so few people use it, it's been in and out of production. So we really just use propofol, which is totally fine for this. The only difference with propofol, if you ever use thiopentone, there's a really definitive endpoint. So you give your determined dose of thiopentone, and at a certain point, 30 seconds later, eyes close and that's it. Whereas with propofol, you give the amount, and the eyes kind of, they're blinking, patients kind of in and out, and then they shut their eyes. And so that's often kind of the difference of propofol. And we use rocuronium and suxamethonium interchangeably, 1.2 milligrams per kilogram rocuronium. There was a study that showed that is marginally faster than suxamethonium. Like there's one study, I think, that showed that it was maybe a few seconds or a fraction of a second faster than Sux, but Sux gives you those fasciculations. You know when the patient's ready without having to time anything or without having to use a nerve twitcher, a single twitch counts to show the degradation of your adductor pollicis muscular function. So that's kind of where most people go. And these days, when you're in emergency, did you see people put cricoid pressure on?
No, I didn't actually. So I haven't actually seen that done. And in reading, it does seem like a tricky skill to kind of master, to know exactly how much pressure to apply to make sure, you're not making it more challenging for the airway operator as well. Yeah.
Actually, let's go through some of these other areas of contention. So I think we've talked about the induction agent. What do you know about ketamine? Like, what's that as an agent?
Yeah, so I guess I've heard ketamine being used as kind of in modified sequence induction. So, if you've got
delayed sequence inductions.
Delayed sequence induction, sorry. Yeah. So, giving the ketamine first, particularly in a, critically unwell patient, or if they've got, significant cardiovascular disease, to then reduce the amount of induction agent that you need to give. So that's kind of the main area that I've seen ketamine used.
And we can absolutely still use it for rapid sequence induction without having any of that delay. It's a really fast-acting agent, maybe marginally slower than the other agents. But again, it's hard to know when the patient is unconscious because their eyes might still be open. And often we just give that a reasonable dose, like 1 to 2 milligrams per kilogram. Definitely less in patients who are hemodynamically unstable, if they've got lots of blood loss or very fragile hearts. And then, we kind of just time it and go, that's about right. But I often combine ketamine with midazolam. So I've got that very immediate amnestic effect of, 3 to even 5 milligrams of midazolam and ketamine together, totally hemodynamically stable in most situations. Plus you're running aramine or miraminol as a vasopressor or ephedrine as an inotrope. It is fantastic for these really sick patients. And I'd use it regularly for emergency cases. Like, people do say it's extremely cardiostable, but take any incredibly sick patient, and because it has an indirect positive, inotropic effect through sympathetic stimulation centrally, but a direct negative inotropic effect, sometimes you get, if the patient's already maximally sympathetically stimulated, like someone who has, incredible amounts of blood loss, then you can't really increase the indirect effect. So it's all direct effects, and therefore you get this, hypotension anyway. Yeah.
Mm.
How about the choice of? I think we've gone through the choice of relaxing, succinylcholine. What do you think of? Like, if you saw this drug, just with all the side effects, like, what do you think of that? Like, just using it seems a bit unusual, right? With so many side effects. What do you think of that?
In regards to succinylcholine side effect profile?
Yeah.
Mm. Yeah, I guess with any drug you give, there's always a risk of adverse reactions. And I guess it's, operator dependent, and also what you've got available in that situation. I don't know, in your experience, that kind of slightly quicker onset of action of succinylcholine, does that have much benefit over rocuronium in your experience?
Only because that study that showed that rocuronium can be marginally quicker, but again, you have to use your nerve twitcher versus the sucks causing fasciculation, so you have a visual endpoint to when your patient is paralyzed. But I just don't see it as a problem. Like, what's the difference between intubating 1 second or 2 seconds faster or slower? Like, I don't think it's clinically significant. But there's an advantage of rocuronium in that, you give that drug and you don't have to give a further drug. So you're exposing them to one drug for paralysis, which may or may not be a benefit in that particular patient. Some people think of rocuronium as a better agent because you can reverse it in some, if there's some level of a difficult airway. But I don't think that's a really great, you have to give, after the intubating dose of rocuronium, you give 16 milligrams per kilogram of sugammadex, and you can reverse rocuronium. But there's no guarantee if you couldn't gain the airway that you'll still be able to gain the airway, because they've already had a big dose of propofol or hypnotic, which is also rendering them apneic. So it's not that, that doesn't save the situation necessarily. But yeah, I think I just use them interchangeably. And if I think I'm going to need further paralysis, I'll probably use rocuronium. That's kind of how I see it. But yeah, the side effects, there's so many side effects, like, hyperkalemia. You get that, increased potassium with succinylcholine. So you really have to watch out in burns patients with extrajunctional receptors, end-stage renal failure. Any sick patient, I always check that potassium before giving it. You could get sux apnea rarely, malignant hypothermia rarely. Second dose of sux often gives a severe bradycardia. And, I've definitely seen people arrest on the second dose of succinylcholine. And then a few other things like increased intragastric, intraocular, intracranial pressure, but these aren't necessarily clinically significant either. What do you think about cricoid pressure?
Yeah, like, as I was touching on before, it seems something that's quite difficult to learn how to do correctly. So I guess in the traditional RSI, you work up to giving that 30 newtons of cricoid pressure, which is roughly about 3 kilos. And I was reading that you can actually, recreate that by compressing air in a 20 ml syringe from 20 to 12 mils. So I guess that's one way you can try and practice your cricoid pressure and know how much force to give. But the problem is, if you're doing too much force, you can then obstruct the airway and make intubation more difficult for the airway operator. So I guess the takeaway thing is, if, it's not working, to consider takeaway cricoid early to kind of try and give yourself a better view of your airway.
Yeah, I think that's exactly my thoughts. I think it's a pretty ingenious thing. I imagine when Selick first described this maneuver, like it's quite an ingenious thing to think that I can make this cricoid ring obstruct the esophagus and prevent this life-threatening complication. And they've done MRI studies, or I can't remember which imaging process they did, to show that done right, it absolutely prevents reflux of gastric contents a lot of the time, or significantly. But the problem is, it's to actually do it, to train people to do it in the right way with the right pressure and make sure that cricoid cartilage is overlying the esophagus, have the right pressure on. There's all these ways that it doesn't actually, the actual efficacy in clinic is not necessarily, there's no real clinical evidence that it works, as well as the fact that, like you mentioned, making the airway harder. And that's a definite thing. Like if you put cricoid pressure on, your airway is almost always more difficult. So if there's definite evidence of difficulty and not that much evidence of benefit, a lot of departments out there, I remember the first one, I think one of the hospitals locally just said in the emergencies, we're not doing cricoid anymore. That's out. And it just became a thing that people didn't do. And I think pretty much there's a few countries around the world that, they routinely do not do cricoid, whereas Australia traditionally did cricoid all the time. And it was a really big thing that we managed every RSI with cricoid. Yeah, in my experience, if the trainee wants to put cricoid on, I say, put it on, but have a very low threshold to take it off. And do I use cricoid? Usually not. And I think if I do use cricoid, I do it just to help train my assistants that it's okay to take it off. So I might use it and say, oh, cricoid off, please. And it'll be quite alarming because that's something they've been taught you cannot take it off until the airway's secure. And so I'm doing it as kind of education that, look, if the airway's not good, this is totally fine to take away because it's far worse to have a bad airway. Yeah. How about peri-induction oxygenation? Like what are the methods that, you've seen used and described, and what do you reckon?
I think the main method I've seen used is just with a like a non-rebreather face mask, maximum flow, 15 liters going. And I guess, it's again that balance between oxygenating the patient and the risk of aspiration. So I guess you don't, in regards to any kind of, bag valve mask, mechanical kind of ventilation during this period. But, with the introduction of high flow now, I imagine that could be used for the oxygenation period as well.
Absolutely. Yes. I mean, at the moment in theatre, we just get the face mask on and it's got a good seal. We give, sometimes I'll give 15 liters to patients just to get that oxygen in and get the end tidal O2 above 80%. So they're really well pre-oxygenated. Sometimes I use PSV Pro for pressure support ventilation as well. That's what we often do in theatre. But yeah, you're right. Like in ED, if you're waiting, you may just hold the Liddell bag on or have high flow nasal oxygenation, like with the Optiflow Thrive. Fantastic way of having constant, having a patient not desaturate. But essentially, the thought was we're not ventilating the patient because ventilating the patient could inflate the stomach, which increases the stomach pressure, which then causes aspiration. And my thoughts are, look, I would routinely use gentle bag mask ventilation. So just making sure I'm not going above 15 centimeters water pressure, which is the lower esophageal sphincter pressure, just gently bagging. And that way, most of the time I can bag the patient gently. So first of all, I'm oxygenating the patient. And second of all, I know that I can bag mask the patient. So I'm very comfortable if this is a difficult intubation, I've got that bag mask handy. And look, if I couldn't bag mask the patient, I probably wouldn't persist at it because after 30 seconds, I'm going to intubate anyway. So I think gentle bag masking provides me a lot of good information and keeps the patient from becoming hypoxemic in a high risk induction. I just think that that's a really useful thing. And I think you mentioned here in the notes as well, patient supine versus head up. What are your thoughts on that?
Well, I mean, optimally, you want them kind of in the sniffing position, really. I guess that's more for your intubation side of the RSI. But I guess, supine versus head up, you're thinking can I improve oxygenation by having the patient sit up and prevent aspiration? But looking at the research in this area, they haven't actually shown any benefits in doing that, and actually worse views on laryngoscopy of the patient sitting up. So I imagine the optimal position would be, patient supine, but in the sniffing position with the head of the bed elevated to about 30 degrees or so.
Yeah, like I'd never have the patient fully head up, but yeah, I'd definitely have them ramp to whatever their airway was best. And I think it's one of those things that it feels obvious that, things don't go against gravity. So if the patient's lying down, if they're going to aspirate because of a, weak sphincter, it's going to happen supine, but it's very hard for fluid to move up a gradient against gravity. So, and it makes sense for the airway as well. Actually, what kind of evidence did you find about, giving oxygen during the apneic period? The Endow trial?
Yeah, so the Endow trial, that was the emergency department use of apneic oxygenation versus usual care during rapid sequence induction. And this was a randomized controlled trial done in the US. And essentially, this was done in 2017, and it showed no difference between the lowest mean oxygen sats with supplemental oxygen during the apneic period, and that compared to not giving any oxygen at all.
Wow, that really surprises me, actually. The fact that they must have really great operators, because you just think it's a time thing. If people are taking longer to do the intubation, then without supplemental oxygen, it's, they're just going to have less time, but potentially with enough good pre-oxygenation, this won't be a problem. But I can imagine in obese patients with high basal metabolic rate, any issues with pre-oxygenation, suddenly that apneic time is going to be lower. So I do wonder what that sample size and what the population was showing with that. Let's go through the steps. We covered RSI and kind of the why you do it and what the method is. So what are the different methods of let's go through the steps of kind of an RSI. So what are the things to consider?
So I guess beforehand, before you're even performing RSI, thinking about, the patient, what position you want them in, pre-oxygenation, how you're going to do that, making sure you've got all your equipment nearby. So like your anaesthetic machine, if you're in theatre and that's all working, all the medications you're going to need, appropriate monitoring, and all your intubating equipment as well.
This is the 4M's checklist. I love this: machine, meds,
stolen from you there.
Yeah, nice.
And depending on where the RSI is going to take place, whether you're in, ED resus or you're in theatre, you want to make sure you've got, the right team there. So I guess for ED resus situation that I've seen, you have your team leader, your airway operator and their assistant, someone to do drugs, someone to scribe, and then if you're going to go with cricoid, someone to apply the pressure there.
Oh yeah, with that team, sometimes, like especially in the really tricky RSIs where there's some other problem with the patient and there's usually hemodynamic instability, that drug administrator is often a senior doctor, who's looking at that art line, blood pressure, heart rate, everything, and just going, oh, yep, I need to give Metaramin, I need to give ephedrine now. So, sometimes you just want in that tricky period someone on the airway, and that's fully their task focus, someone on the drugs, and that's their task focus, and often they might be the leader as well, or, having a separate leader. Yeah.
And then I guess with any kind of procedure in a high acuity situation, you want to make sure you've communicated things to the rest of your team and that everyone knows this is going to be plan A, plan B, plan C. This is when we're going to change over operators if that's something you're going to do as well.
Excellent. So then the traditional approach, let's just run through that.
So traditional, firstly popping the nasogastric in to kind of aspirate any stomach contents was actually, what I read.
There was actually a ruling, like a Australian legal ruling, that if there's a nasogastric, it was when a patient did aspirated on induction. So the ruling was if there wasn't a nasogastric already in situ, you wouldn't necessarily put it in for the RSI. But if there's already one in place, you get one of those big 60 ml syringes and aspirate on the end of it to relieve whatever there is. So if there is one in, aspirate it. If there isn't, you generally don't need to, or there's often no specific clinical need to put one in.
Yeah. Okay. Right. So I guess if you've got one in, you'd aspirate. Otherwise, you'd move straight on to positioning the patient correctly. So in the sniffing position, so you've got neck flexion at 35 degrees and face plane extension at 15 degrees. If you've got a patient with a bigger BMI, you might consider putting in a wedge underneath their shoulders just so you can get their sternum kind of at the same line level at their tragus or angle of the jaw. You make sure all your equipment's working, you've got suction ready to go, you've got all your monitoring attached, start pre-oxygenating your patient. So as you were talking about before with that tight fitting mask, 15 litres, and really for 3 or 5 minutes or so until you get your end tidal oxygen above 85%. And so from there, if you're going to use cricoid, that's where you then start. So slowly applying 10 newtons of pressure. You'd give your induction agent and then quickly your neuromuscular blockade. And then at that point, you'd increase the cricoid to about 30 newtons when the patient fully loses consciousness. And then you'd go on to intubate. So in this situation, say you're using succinylcholine 30 to 45 seconds after that's been given, or when the fasciculations end, 45 to 60 seconds roughly if you're going to use rock. And then once you've got your tube in, inflating the cuff and confirming position with making sure the tube's fogging, equal chest rise and fall. You've got your end tidal trace and you've auscultated both sides of the chest. And then once the tube's in position, it's at that point that you would then remove your cricoid.
Yeah, fantastic. And that's exactly what most people would do with a rapid sequence induction. And it's interesting. So I'm a big fan of listening to every chest unit. Check the fogging, check the rise and fall of the chest. At that same time, you're then auscultating. I first auscultate the stomach region and then both sides of the chest. And the reason I do that is if you auscultate, let's say someone did an endosophageal intubation, so they're essentially insufflating the stomach. If you were to then listen to both lungs, that sound of the stomach transmitting through the lungs sounds like brilliant equal air entry in many patients. And so I always listen to the stomach first, where you'll often hear gurgling sounds if it's down there, if it's down the wrong pathway. And then I auscultate the lungs. So that can, the absence of sound in the stomach confirms no esophageal intubation. And then I listen to both axilla. And I know this is not something that most people do, but I've just seen a critical incident happen because that didn't happen. I remember one of my consultants back in the day was fantastic about this. I remember he just drilled into me that every single intubation, you do these steps, check for fogging, check then, stethoscope on, stomach, axilla left, axilla right. Then you look up and the end tidal CO2 is now present. So you haven't wasted any time. You've got lots of good information and you've confirmed it's in, and you've listened to the lungs the first time they've been intubated. So the first sign of bronchospasm will be that first listen, and you'll be able to get onto it so quickly, unlike if you didn't auscultate the lung. So really big fan of such a simple, non-invasive step with so much benefit. Hey, so I thought we might run through these. There's definitely a few different scenarios, and I thought I might just give my experience of these. So
yeah, definitely.
Often you just have a really shocked patient, massive blood loss, they're peri-arrest. And often, because they may have limited levels of consciousness, you don't need to give too much medication. So think of, this could range from the motor vehicle accident or splenic rupture or PPH, where they've lost 3-4 liters of blood and you're just pumping in fluid and blood while you need to get them to theater. To give the normal dose of, say, 1 or even 2 milligrams per kilogram propofol, that could be a dose that completely arrests this patient. So we have to be really careful. So the options you have then are to do, first of all, make sure you're fluid running, make sure you're in theater with all your usual staff and supports and hands. But the agents you have are ketamine at a lower dose, and often I'd give, again, depending on situation, definitely get your supervisor's advice and your team's advice, and this is just general advice. But ketamine at a lower dose, often anywhere from 0.5 to 1 milligram per kilogram. I might even just give midazolam and succinylcholine sometimes. Other times I might give a tiny bit of propofol, 1 to 2 mils of propofol, maybe all you need in an elderly patient with substantial blood loss. And all the time I've got ephedrine ready for positive inotropy and metaraminol ready as a vasopressor. So a lot of things in place to make sure that shock patients don't arrest.
And we touched a little bit about patients with significant cardiovascular disease and how you'd modify RSI for them. What would you do, for a patient that's critically unwell, significant cardiovascular disease? How would you approach that situation?
Yeah, so this is I've actually got a video on the critical inductions that are cardiovascularly relevant. There's probably a couple of videos on YouTube for that. But essentially, in these patients, let's take the worst is like cardiomyopathy patient with an ejection fraction of like 10 or 15%. You really want to try and maintain normality for everything. So the way I'd approach that for a rapid sequence induction, actually the way I'd approach it for any elective induction, and I'd prioritize the cardiovascular status over the aspiration risk, because that's where most of the mortality is going to be. So I would absolutely give a large dose of say something like fentanyl, which is generally thought to be more cardiostable than giving more rapidly acting agents like remifentanil or alfentanil. So I'd do that. I'd give midazolam. I'd have ephedrine and metaraminol running. And again, I'd titrate really low doses of other agents. It could be a bit of propofol, a bit of midazolam. And the difference between this versus the shock patient is the fact that I'm, trying to avoid that tachycardia in this patient, whereas I don't really care about the tachycardia in the shock patient because I really want that sympathetic drive to be maintained. So I might give a bit of fentanyl in a shock patient, in a hypovolemic shock patient, but I won't really give massive doses of fentanyl, unlike with a cardiovascular disease, cardiomyopathy patient. And I'm really just trying to avoid the tachycardia, which then increases the amount of myocardial oxygen demand and then decreases supply, because now the diastolic filling time and the diastolic is time for the coronary artery blood supply or flow to the heart is now decreased.
Yeah. And what about, say, you have a situation where patients coming with head trauma, that they're hemodynamically stable, but need to be intubated quickly? How would you modify for that situation?
Yeah, so head traumas can be quite tricky. So there's a particular kind of let's take the trickiest induction, which would be an unstable, unclipped subarachnoid hemorrhage. It's not exactly head trauma, but this is where any sharp rise in blood pressure, which increases this transmural pressure gradient, which is the pressure across the mural, meaning the wall of the vessel. If the blood pressure goes up or the intracranial pressure suddenly goes down, you now have a risk of re-rupture. And with rupture, there's like a 50 to 70% mortality straight on that event happening. So I really, really want to prevent the spikes in blood pressure more so than I care about the, say, causing a bit of hypotension that I can then treat. So you think of this patient, say a 50-year-old female, subarachnoid hemorrhage, unclipped, needs to go for clipping. I would probably give a decent dose of propofol, so anywhere from 1 to 2 milligrams per kilogram, and I'd give a fast-acting relaxant like rocuronium, and I'd give a decent dose of something like alfentanil, or I'll be running remifentanil for really good sympathetic ablation to laryngoscopy. And I'd have another drug ready. I might have phentolamine, which is an alpha blocker, or esmolol, which is a rapid-acting beta blocker, to just prevent that. Just have something extra to prevent that spike in blood pressure. So there's again a whole series of ways. Like for example, with alfentanil, probably give 10 to 20 mics per kilo. Look for that bradycardia. Same with Remi. Have it running at start with 0.05. While you're getting things ready, mics per kilo per minute, that is. Then you can increase to 0.2 mics per kilo per minute. Or if you're using nanograms for TCI methods, you might start at 1 to 2 and then increase to maybe 4. And you're looking for that bradycardia. You're looking for that sign that this patient has that analgesia working. And I think the extra thing that people don't realize is not necessarily how much or the type of analgesia you give, but you try to make your laryngoscopy as gentle as possible. And so if you're really sticking that tip into the vallecula, you're going to get some incredible blood pressure spikes. But if you use a video laryngoscope and use as gentle pressure as possible, it's a lot easier to minimize those hypertensive episodes. So that's basically what I do for those subarach cases. And if it is head injury, it's kind of similar. Like I just want to maintain hemodynamic stability. So, I probably care more about having a little bit of blood pressure drop over a small period of time is probably not as bad as having a sudden blood pressure spike. And I'm just trying to, prevent a sharp rise in intracranial pressure. And there's always that dilemma of, you've got a patient who's bleeding out, and you've got a tight brain. You need to have hypotensive resuscitation, but also you need to perfuse the brain. So I need to, make sure my blood pressure is perfusing the brain as well. So very tricky situation. You'd absolutely be managing this with an experienced clinician.
Oh yeah, for sure. And your final example we're going to touch on, so a preeclamptic patient who's going for an emergency Caesar. How would you, modify your RSI for this situation?
This is actually really tricky. So in a patient who's, let's say, a straight cesarean section for a GA Caesar, so baby has some level of problem, and you need to do a GA, you can often just do this cesarean section by giving a big dose of propofol, avoid opioids because then nothing gets to the baby. And that way the baby hopefully comes out not as flat as if you gave alfentanil or something else. So that's probably a method we've used for just a cesarean section. Don't worry about that. Your patient becoming tachycardic, as long as they're amnestic, it won't be a problem. And young female patients can often tolerate tachycardia because these patients don't have the cardiac problem or the cardiac disease that other patients do, that other patients might. But if you've got a preeclamptic patient, it's kind of the same thing. The mortality of preeclampsia is, some people would say it's the seizures, but it's actually intracranial hemorrhage because your vessels are essentially not normal vessels, and you've got hypertension. And what this means is you've got this incredibly high risk of intracranial hemorrhage. And so I would approach it similarly. I would absolutely give an opioid in this situation, and it's probably alfentanil. And I might want to chase that again with a beta blocker or phentolamine or lignocaine or something, just to try and avoid that. And again, gentle laryngoscopy. You'll always have pediatrics or an experienced midwife there after delivery of the baby, because the baby's going to come out of it flat, and they'll potentially need resuscitation as well. But I'd approach the preeclamptic patient very similarly to the subrac patient.
Interesting. Well, that we've finished up now, but that was really interesting, and certainly, really good to have your insight there into how you'd approach different situations. And I hope that now anyone listening or you're seeing a situation like this in whatever area of the hospital you're in, you have a bit more of an understanding, and then to know a bit about what's going on and why, certain things are being done and for what reason.
And really got to thank you. You've done a great amount of research on this. So in the show notes to this, we'll put the references to really, really good articles, and Life in the Fast Lane, just a fantastic website. I get so much great anesthetic and quick care information from there. And so, we will probably sign off there. And thanks so much for doing this podcast.
Awesome. Thanks so much, Lahiru.
No worries. So, everyone, thanks very much for listening and watching on YouTube. So, share with anyone who might be interested, and we'll see you guys all next time. Now, what's new with ABCs of Anesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.